session for this quarter of the class. Hopefully everyone continues on to the next quarter because we've got a lot of great speakers lined up for that. But today we'll have Josephine Ensign from the School of Nursing talk about youth and homelessness, and then commercial sex exploitation of children, which is what CSEC stands for. So I think everyone signed in. If you haven't, there's a half-filled sheet right here. And then everyone has the surveys as well. So today we're going to start a little bit different. Usually it's me up here talking for 10 minutes just rambling. But today we'll have two other speakers come up and kind of talk about outreach they've done. But don't be scared like that little kid might be. We'll all be fine. So first I'll have Mary. She's a nursing student, and she is going to talk about 2 outreach activities that she has done while participating in this course. So you can just hold that.
So my name is Mary. I'm in the Masters of Nursing at UW-Bothell. And I'm one of the 2 or 3 nursing students in here. So what I did for my outreach is I went to Nurse Legislative Day. It was at Great Wolf Lodge. And some of the things that they talked about had to do with patient safety. They also talked about Medicaid expansion and some of the health care reform. But I also thought that that would give me an opportunity to actually do some advocating for homelessness and kind of connect it to this class. So before I went to Nurse Legislative Day, I thought that I would do some research, as all good students do, right? We go to the internet, and I actually went to the One Day Count website, and I found a workshop that was conducted by the Seattle and King County Coalition on Homelessness and the actually the Faith Action Transforming Homelessness groups. And they provided a workshop headed by a person who was a state and federal policy associate, and Nancy Amadei, who was here last month. And they conducted a workshop that kind of gave us the top legislative priorities for this legislative session, as well as Nancy kind of gave us how to advocate in Olympia. Some of the top priorities that they talked about, even though there were 6 top priorities this year, they wanted to focus on investing at least $175 million in the Housing Trust Fund, which was one, and then preserve and strengthen our Disability Lifeline, which is another one, and make tenant screening reports fair and accurate for all renters. So I kind of researched these things. They talked about it, and then I went the afternoon of Nurse Legislative Day. They actually chartered buses to take us from Great Wolf Lodge to the Capitol. And I had never advocated, so I thought, you know, I would do a little research of that. So what I did was I put on my armor that they gave us, and I was ready to go to advocate. So I did meet with well, I met with a legislative aide for my senator because he was not there, and I did meet for a representative, and I discussed these issues with him. And as I was heading up to the Capitol, I saw these signs, and Nancy Amadei was actually there the same day I was with her group, and they were advocating for some of those same issues. So I had went and I talked as well, and I also followed up with an email because they said that was very important to follow up and give a personal statement of you know, why you're doing this. So I did that, and also I put this little quote from Gandhi. It's kind of been following me through some of my studies because I think it's important. And it says nothing we do as individuals matter, but it's vitally important that we do it anyway. And, you know, we have a voice. And I think collectively, you know, we don't know. We just keep doing it. So anyway, that was my outreach.
Thank you for that. So now I'll have Patrick Clark talk about an event that we did yesterday.
Hi, I'm Patrick. I'm a second-year dental student, for those that don't already know that. So yesterday, just a group of us went down to Mary's Place, which is a homeless women's shelter in downtown Seattle. We were a mixed group. There were dental students, there were nursing students, there were medical students, and we even had a pharmacist that came with us. And I haven't had a chance to see the stats, but it looks like 35 adults and 9 children. I felt busy the entire time. We were doing oral health screenings on the dental side, and then foot exams on the medical and nursing side. And it was really cool just to see that many people and give that kind of care to such an underserved population. And for me personally, it was also really cool to see how my medical and nursing colleagues did their thing on their side.
So some of the patients that we did see at Mary's Place, we had referrals set up, so when we were doing the screenings, we could look for decay or look for anything they needed work done on, and refer those patients actually to Union Gospel Mission on the same day. Although they're not located in the same area geographically, we were able to, get bus tickets for those people to get down there, and hopefully for their families as well. So we had the third and I think just third-year students doing comprehensive care at the clinic. I don't know if anyone can add. Well, if you participate in any other outreach that we don't highlight, I'd love for you to come, the next session or one of the subsequent sessions and talk about what you do. Part of this class is, talking about ideas and ways that you can work with homeless populations and things you see, things that work, things that don't work. So let me know. So on that note, we'll have Josephine Ensign start. Josephine is an associate professor in the University of Washington School of Nursing, Department of Psychosocial and Community Health. She has adjunct appointments in the School of Public Health and Community Medicine and in Women's Studies. A family nurse practitioner, Ensign has a doctorate in International Public Health from Johns Hopkins. She has done clinical work and research for the past 24 years, focusing on underserved populations and homeless youth. She also teaches nursing and conjoint classes. Ensign has a special interest in applying practices and approaches from international health, and I actually found this picture from her in Thailand?
Under a bridge in Bangkok.
Look what Google can do. Sorry about that. If you didn't like that, I don't know. In 2003, she received a Fulbright Fellowship to spend 6 months at Chiang Mai University in Thailand. During her time there, she worked with faculty to develop advanced research practices and learned about Thai policies and perspectives on high-risk adolescent health issues and community-based research. I've also worked with her on the Teeth and Toes clinics and with the Health Sciences Service Learning Committee. So let's welcome Josephine Ensign.
Was when I had red hair. What can I say? So you want me to use the thing?
Oh yeah.
That works. So welcome everybody. I'd like this to be a little bit more interactive. So feel free to stop me anytime if you have comments or questions at all, because I don't want to just get up and just do a straight lecture. And I don't typically do exactly what I'm asked to do. So I'm going to talk about marginalized youth and what we call CSEC youth, commercially sexually exploited children, because I've worked pretty much exclusively with that population for about the past 16 or so years. But I want to, because this is about health and homelessness, right, this whole class. So I want to start off talking with you a little bit more about things that I'm reflecting on in terms of my entire career, which now is 30 years working directly with homeless involved individuals. Okay? So I started off my work with homeless populations in my hometown of Richmond, Virginia, which this is a photograph of the James River as it goes through downtown Richmond, showing you some of the bridges where my patients, this was back in the 1980s, when there was a burgeoning number of very visible homeless people on our nation's streets. Richmond had more than its fair share of homeless people, because any of you who've ever been through there, geographically, it's at the crossroads of 2 major East Coast interstates and also some major freight lines. So people passing through get stuck for various reasons. This is showing some of the bridges where my patients back then lived and where they continue to live. I still have contact with a fair number of them. And I started working with the homeless population while I was still in nursing school. And as soon as I graduated, my first job was starting one of the first healthcare for the homeless clinics in the country, which was kind of interesting. So Richmond is part of the black belt of southern poverty, where people continue to have the worst health and shortest life expectancies of any region in the U.S. And if you really want to see dental problems, go to the south. And this shows some current inner city housing stock in the area of Richmond where I was working at the time. And this is the Richmond Street Center, which was a multi-service center for the homeless that started in the 1980s and ran through the early 1990s. And it's where I had a clinic and where we started healthcare for the homeless clinic in the heart of downtown Richmond. So this is me working with foot care. You can see, I was doing foot care yesterday at the teeth and toes clinics. We had no idea how the clinic would even be utilized when we first opened. I was a nurse practitioner, am a nurse practitioner, and was the only healthcare provider for the first 2.5 years of the clinic's existence. So, you know, the nurse practitioner role, those of you that are nurses in here know that it was a fairly new role at the time. And we didn't, even know how well it would be accepted by the homeless population. It was mostly homeless men, because this was like the hardcore homeless population in Richmond. And by the end of the first year, I'd seen 1,600 patients for over 4,000 encounters, and it grew exponentially. And that's why we were able to get one of the first healthcare for the homeless grants and hired a full-time physician and a clinic nurse that kind of took over that part of it. And during this time, I became homeless. And there are various contributors to that, but including some systems level issues that happen in terms of a run-in with the Virginia Medical Board over nurse practitioner scope of practice issues, which led me to lose my job, disillusion of my marriage, and spiral into homelessness. And I crashed and burned and spent about 6 months couch surfing, living in my car in an abandoned shed, before moving to Baltimore to go to grad school. Kind of proving that in our country, at least, there are many paths into and out of homelessness. But I say this because it's kind of a cautionary tale to all of you. I mean, I know you're all in here and you're very interested at some level in terms of homelessness. But to recognize that homeless people are not so different from us, that you might not have anybody in your family or anybody that you know in your friendship network who has experienced homelessness, but it happens. I mean, homelessness is basically poverty, a lack of affordable housing, and all sorts of other kinds of issues. And yes, there are individual vulnerabilities in terms of substance abuse or mental health issues and things like that, but it's really about our society not having an adequate safety net. And the other thing that I just want to say to you all, because hopefully all of you will do some type of safety net healthcare work, even if you go into like private practice, that hopefully you continue at some level in terms of community health clinics like 45th Street Homeless Youth Clinic, or some of these things like the teeth and toes, and is to realize that in our country, the safety net healthcare system is built on the principle of charity care, which engenders stigma, shame, dependency, and resentment among recipients. And it's also a huge recipe for burnout among the providers of this healthcare. Because if you think about it, in our country, and this, this is not a political statement, no matter where you are on the whole political spectrum, but if you have done work or if you've lived in other countries, especially industrialized countries, that our country really stands out in terms of not having an adequate safety net in terms of basic economic, job training, and all of those types of, or housing. So healthcare safety net providers and services end up not only providing healthcare, like your dental extraction yesterday, but they're also struggling to provide the basic kind of economic, social supports that our society doesn't provide. And the other thing is, and to think about, even like with the teeth and toes clinics, is that safety net healthcare also further fragments our already deeply fragmented healthcare system. If we had some type of basic healthcare services, the different programs, like even 45th Street Homeless Youth Clinic, again, where I've worked, versus Country Doctor, Homeless Teen Clinic in Capitol Hill, which is a program through the School of Medicine here, they wouldn't be vying for patients or funding to stay alive. So just to kind of think about that with you go through. And I was asking Patrick before class if it's still true. I mean, we were always taught within different kinds of healthcare that, and I know the majority here are dentists, that dentists have one of the highest suicide rates among healthcare providers. You get, Patrick says he gets asked this, but he's not sure if it's...
I think you've been taught mixed.
Mixed?
I think it's evened out according to our most recent class.
Oh, because ours has gone up.
Yeah.
That's good. That's good. All right. So, but in any case, that in terms of access to drug diversion, dealing with difficult patients, difficult coworkers, and difficult working experiences, is to really pay attention to yourself in terms of your own burnout potential. And for me personally, for one thing, just kind of stepping back about my experience being homeless is not something that I have been willing to talk about until more recently. Homelessness is stigmatizing, because if you tell somebody you're homeless and they know that you were homeless as a young adult or onwards, you weren't homeless as a kid where people kind of forgive you, right? Because it must be your parents' fault. People automatically go, what was wrong? What's wrong with that person? So to think about that in terms of just how stigmatizing homelessness is. Even the women who we were dealing with yesterday at Mary's place aren't necessarily going to want to even identify as homeless, because it says a whole lot about you. But also for me, in terms of dealing with burnout, has been something that's really important that I've moved into more recently, is writing about it. Of taking time to do whatever it is that helps you to not only recover. I heard Orcas Island retreat. Yay, Orcas Island. I heard beers at Blue Sushi. Yay, beers at Blue Sushi. I mean, those are all things about taking care of ourselves, being in in community and social support. But to also think about having some time built in to not only your education here, but in your future practices of reflecting on what's going on for you at work. How is what I'm doing really benefiting not just the woman that was in pain yesterday, which, thank goodness you were able to do with a tooth extraction or whatever to have her not be in pain, but also what are we doing upstream, like the advocacy kinds of works. And doing that, the advocacy work, is actually a type of burnout prevention, because you feel like you're actually doing something more upstream to affect what's going on with the people who you're working with. But if you're at all into writing, to also try to incorporate that into your writing. And do people, have you heard of the whole kind of field of narrative medicine? Anybody? No? It's out of Columbia University, and it's kind of extending medical humanities, which has been around forever, but of looking at different kinds of creative writing, both for people who are in healthcare as a way of reflecting on what's going on, like difficult patients, but also for healthcare providers to read different kinds of creative writing from people who have had other experiences, so that you get to access a little bit more of what it might be like to be in that. You can't ever be in that person's shoes, but at least to really recognize what's going on with that. So in that line, and I promise you we'll go to homeless youth, but I first want to read you something that I have written that's related to teeth and homelessness. So this is back, this is from a narrative nonfiction book that I'm just finishing writing called Catching Homelessness, which is the story of my work with homeless people at the Richmond Street Center in the 1980s while navigating my own passage through homelessness. And when all of the patients that I have in the scenarios, I have protected their identities. I've kept it true to what happened, but changed certain kind of identifying kinds of things. So I'm just going to read you a short one that's from a chapter that I just finished that's called Relics. And this is about, just a brief background, it's about and back in the 1980s, we called people mentally retarded. I mean, that was still an accepted term. So it was working with 2 adult mentally retarded patients who were living in kind of neighborhoods around the street center. One lived in a group home. And specifically about Sally, who had an IQ of about 45 and ended up getting pregnant. And it was about the ethics of trying to figure out how to deal with her pregnancy. So Sally, and she had a really bad stuttering problem as well. She came into clinic one day with Harold, her boyfriend, and I already knew Harold. He was a regular at our dental clinic. I forgot to tell you, the street center, we also had a dental clinic with volunteer dentists like you doing kind of like what must be at the Union Gospel Mission. I already knew Harold. He was a regular at dental clinic. He was mentally slow. I didn't know his official IQ score, but he functioned at a much higher level than Sally did. He worked at a grocery store sweeping floors, and he lived in one of the Chamberlain Avenue group homes. Harold had a misshapen face with a severely undersized lower jaw and a perpetual grin revealing a set of teeth that resembled bombed-out ruins of a city. The volunteer dentists who came in at the street center clinic on Saturdays told me they'd never seen a mouth as bad as Harold's. They took photographs to use in classes in the dental school. And Harold's teeth were so badly decayed that the dentist had to replace them with full dentures. He was only 28 at the time and was proud of his dentures. Harold insisted on giving me the stone mold of his lower jaw to use as a paperweight on my desk. He told me it was something to remember him by. Whenever he and Sally came into clinic together, he would check to make sure I still had his teeth on my desk. Sally would pick up the stone mold and pretend it was talking. For some reason, her stuttering smoothed out, and I could understand her better when she played ventriloquist. Harold grinned, showing off his dentures, but he always made sure Sally returned his teeth to my desk. I wish I could tell Harold that the stone mold of his teeth sits beside me on my desk as I write this. I wish I could tell myself why I've kept his teeth so long. Perhaps the stone mold of his teeth is a relic of unearthed truths I no longer want buried. And the chapter also has to do with the fact that Virginia has the highest rate in the country of forced sterilizations of people who were deemed incompetent. It was part of the whole eugenics movement that hopefully you know about, that actually the Nazi physicians in World War II looked to Virginia and the Supreme Court ruling in favor of it, of forcing sterilizations on people like Sally and Harold. So it was about that as well. So that's a segue, right? So any questions about that part of it in terms of the burnout prevention, the thinking about, reflecting on what you're doing? Because then I want to do a little switch to young people that I've worked with.
Did she carry the baby to term, or?
She did. I mean, it's also obviously, it's set in Richmond. It's also about racism, and the baby ended up being mixed race, and she was white from Oregon Hill, which is a very racist white area, poor white area of Richmond. So they rejected the baby. So, any other questions about it? No? Okay. So, and this is a population that after Richmond, when I moved to Baltimore to work on my doctorate, I started getting involved specifically with street-involved youth. And I was in Baltimore the years 91 to 95, which are the same years as the HBO series The Wire, if you've seen that. When Baltimore had the highest homicide rate in the country, the highest syphilis rate, and among the highest HIV/AIDS rate. So I've been working pretty much exclusively with homeless, street-involved young people since that time. And on both coasts of the U.S., here in Seattle as well. And then as you found the photograph of me also in Thailand and a little bit in Venezuela when Chavez was first coming into power, which was an interesting thing. And I don't have a whole lot of time, and I always hesitate to get in this too much because in terms of focusing on the commercial sexual exploitation of children and youth, because it stirs up a lot of emotions for people, and it also just seems kind of weird to me that we just kind of like do this little surface thing about something that really is fundamentally very wrong with our society. So I just want to give you that caveat. But I also have heard from some medical and dental students that they don't get really any exposure to this population, and as you're starting to probably be aware in the news here locally, it's something that's a real problem, and you as dentists and as nurses are going to be interacting with especially young people who have been involved with this. So I just want to give you that caveat that I'm going to give you some of these resources, but to just kind of check yourself of what kinds of things it comes up for you. So these are just some different terms. And I know you have gone over like the whole definition of homelessness and street-involved youth here locally, so I won't belabor that. But just the commercial sexual exploitation of children instead of prostituted is used on purpose. I mean, if you think about it, it again goes to agency of like what's really going on. It's a very cumbersome term though, right? So you'll hear the term, the acronym CSEC, youth, is how it's often talked about. And that's how I'll talk about it from now on. This is a photograph from Thailand. As you probably know, Thailand is a huge, has a very big problem in terms of prostitution and then also sexual exploitation of children. And a lot of sex tourism. And you probably have heard that, and different people, mostly men, who go to Thailand just for sex with children. So that's the Fulbright that I had for about 6 months, and I ended up spending about 4 years in Thailand, was focusing on that kind of issue in Thailand, but we also have it right here. You know, again, we think of the other, like it has to be this exotic place, but it happens right here in our backyards. And this is the official definition of human trafficking. There was a fairly interesting article just, I think, on Sunday in the Seattle Times, if anybody still reads the newspaper. I barely read the Seattle Times. But anyway, this is the official federal definition of human trafficking. So the main things to point out here is that, especially for children under age 18, that it's any children involved in the sex trade. So for instance, when I worked with young people at the 45th Street Homeless Youth Clinic who are involved in survival sex, they are actually CSEC and youth and also trafficked. So just to kind of understand that. And it does not have to, a common misperception about it is that trafficking, you have to cross state lines, and that's not true, or international borders. This is the official definition. This is a young woman in a hill tribe in the north part of Thailand where I was working, who was very smart and wanted to become a nurse. And her father was just like this very loving, protective father, and was worried about her going to Chiang Mai to go to nursing school because he knew that, you know, the lures in terms of going into sex trade was really a big problem. So he was talking with some of the nursing faculty from Chiang Mai University about how to have her housed in a way that was going to be protective for her. And this one, again, just kind of like looking at ourselves in terms of our own country, that the UN Convention on the Rights of the Child that covers all these different kinds of things, including sex trade, that our country has still not signed on. We're the only country with Somalia. And Somalia hasn't signed on because they don't have a central government. So that's something that is always kind of sobering to me, of like why we haven't done that. And there's some interesting reasons behind that. And this one also, in terms of human rights issues, is this is the most recent data, and this is for, you know, homelessness in general, not just young people, but of how many unprovoked physical assaults on homeless people there were and how many deaths. And there's a movement nationally to try and have this added to hate crimes. Right now it's not. questions. And then, you know, how many teenagers are buried each year in unmarked graves. So this one, again, is rather sobering. A mortality rate for homeless and street-involved youth is 11 times that of the general housed and kind of like matched for poverty kinds of levels population. There's a new paper that's coming out from the American Journal of Public Health that is replicating this pretty much. It's like 8 or 9 times, and it's out of San Francisco. So it's showing that it's not just in Canada. And not surprising, the main sources were suicide and drug overdose, which, especially for our dental patients, is a huge problem, and why we don't do narcotics with this population, because of the propensity for either accidental or on purpose, or usually it's kind of like both together, overdose from narcotics. And this one, I know you've had a little bit in terms of just some of the estimates and the reasons. And this, in terms of reasons for homelessness for young people, I'm including kind of a worldwide perspective, a global health. So that's why you see some of the things like military repression. That's a huge one in Burma, where I also did a little bit of work, Myanmar. And the whole issue of lack of national identity and birth registry, which is a problem in our country, but that's a huge problem in Thailand, because even indigenous groups like the Hill Tribe, young girl I showed you in the north of Thailand, they're denied citizenship in Thailand because they're not considered ethnic Thai. And this one, in terms of that kind of the link of poverty and homelessness, it's a little bit more of an equal opportunity for young people than it is for adults. But the big thing is that poverty and, you know, lack of getting jobs, like you were hearing about from the Roots young people, leads to chronic homelessness. And some of the most kind of like gut-wrenching young people I've worked with have been young people who aged out of the foster care system, have had like 19 different foster care placements, had no preparation for getting a job, all that kind of a thing. They're about to age out of the homeless youth services in Seattle, which here is mostly like age 24. And where they're realizing that they're about to enter the adult homeless population and facing this like life that they see no way out of homelessness. And that those are pretty difficult kinds of things to deal with. So the Commercial Sex Act includes all of these different kinds of things. You probably have also read in the Daily that there have been med students who have put themselves through med school by being escorts. And to think about it, I teach in you know, in kind of like now in women's studies, but it's gender women's. I don't know. They've extended the name of the department here, and consider myself a feminist. But the whole issue for me of prostitution as being women's empowerment, I don't buy anymore. I mean, personally, because I think it's demeaning, it's degrading, and it's having your body used for, you know, things in terms of intimacy that that I think, you know, it makes a weird thing. So that's just a little personal statement about it. But to realize that there are a fair number of UW students, including health profession students, who actually help to get themselves through school through some of these kinds of things. And survival sex, hopefully you all know that term. It just means trading sex for basic survival needs. You know, Maslow's hierarchy, so it's food, clothing, shelter, a place to get off the streets. And who's at risk? And this is where you see that there's a lot of overlap for homeless and runaway youth. A common kind of antecedent to homelessness for young people is a history of sexual abuse in the family of origin, in the foster care family, whatever that is. And then, of course, life on the streets, they're even more at risk for being sexually abused. So, this just shows that 90% have a history of sexual abuse. One thing I want to add, I looked at the previous speakers who you've had in class, and I know that they covered some about this, but to recognize, especially for those of you who are in dentistry school, that sexual abuse often has been, especially with pediatric populations, has been forced oral sex. So that's a huge, huge reason for fear of dentists. Because have you had that? Interesting. That's a really big reason. I mean, there can have it's an entry to the body, right? And it's oftentimes for young people has been when they have been forced in terms of the oral sex. So to realize that in terms of young people who may have just this like kind of crazy, what you think is a crazy fear of dentists that just doesn't make any sense, that at least to have on your radar that could be because of former sexual abuse or current sexual abuse. And environmental risk factors, Seattle is a nexus for CSEC youth because we have a lot of these things, right? Oftentimes kind of ports or border, and we're right on the border with Canada, but then we're also a major port. And areas around airports are huge places for CSEC youth to be, as well as around like the Greyhound bus station where we were yesterday. Okay. And then, this is just kind of like stepping back and looking at societal reasons or what contributes to perpetuation of CSEC youth. In prevalence, there was a fairly good study here, just focus on Seattle, that there are about 300 to 500 young people every year in Seattle. And this, they were including teens and young adults that are commercially sexually exploited in Seattle every year. And this one I'm not going to show, but if you're interested in this topic a little bit more, this is an excellent YouTube video that we sometimes use in trainings that I do with youth care that is done about the GYMS program in New York City that was started, and it's run by a young woman who was formerly a teen prostitute. So it's a really good way in terms of the grooming that happens with how young, especially girls, get lured into the industry. And this one won't, how many of you work over at 45th Street Homeless Youth Clinic? So you know this one because we have a dental clinic. And you know that the dental clinic for the Homeless Youth Clinic really got started because of one of you all, right? Who really, excuse me? Yeah. Who really championed that. And that, I worked at 45th Street Homeless Youth Clinic for 16 years, and just having the dentists there and kind of co-located, because again, if I was working with a young woman, for instance, and I knew her history in terms of even sexual abuse, and we had therapists there as well, that we could work with her to like move her closer to you all, to to finally get something done. And to just be aware, Youth Care has, Youth Care, it's a local youth serving agency. They have Orion Center downtown near REI. And they also have a program just for CSEC teens that's located in the U District. And some of the main health problems are all of these. Again, the dental problems are huge, malnutrition, eating disorders. Go with it. Injuries, so sometimes injuries even like to the face or the mouth. And then a huge one that's underlying everything is depression and PTSD that doesn't always get addressed in a very culturally competent way, or there's really a lack of adequate mental health services for this population. And the health effects specifically of sex work and prostitution, and this is the one I want to focus on, is that it really looks like it's the control that the young woman or the young man or transgendered person has over what's going on with them, of what some of the access and health effects are to that. And all of these barriers to care. And one thing I also wanted to point out that Trilby addressed, but I want to counter what Trilby told you, is the BECA bill. Do you remember when she talked with you about the BECA bill? The BECA bill is currently being, it's in an active bill in the state legislature, looking at expanding it to 72 hours for mandatory reporting. And it does not affect healthcare providers. You are not legally mandated to turn a young person in. They purposely, I mean, the 8-hour limit they had, and it actually expired at the end of 2012. But they purposely had that so that it was more for somebody who was sheltering the young person. So it affects shelter providers like youth care, but it does not affect healthcare providers, because they know that they don't want that as a barrier to young people going to see you. So I just wanted to clarify that. I've never turned a young person in, you know, who was run away. And all of these, including stigma. But this one I want to focus on, and I know you all need to be out of here by 20 after. But the big one in terms of dissociation, do you have much in terms of dissociation? Do you know what that is? A little bit. That's related to PTSD. It's kind of in informal parlance, it's the out-of-body experience. It's where you go someplace else when you're in an extremely stressful environment. So I always liken it to any of you that are Star Trekkies, the beam me up Scotty, you know, you're like, beam me up, and they go somewhere else. It's a coping mechanism for if you're in an extreme kind of danger, or like you're having forced sex on you and things like that, whatever the trauma is, that you go somewhere else. You get out of your body. And so dissociative disorders are very, very common with homeless populations, and especially homeless youth. So to realize that might be going on, like even in the dental chair, they seem to be checking out that you need to really be aware of what's going on. And then the kind of like the flip side of it, which is really from the same thing, it's really from trauma, is the whole thing of somaticizing. So the worried well patient, or the person that just kind of keeps going back and saying, chronic pain patient who you might have, again, to have your antenna up about that could be something going on in terms of unmet mental health needs. So I'm going to stop there. Are there any questions at all? Just want to show you couple of things. Oh, look, I had it. Is to help them create a safety plan, maintain appropriate boundaries. You can't save anybody. That will not help at all. And then just the screening questions. A standard screening question is, have you ever traded sex for money or other things you need to survive? So it makes it so it's not judgmental, but it's just kind of an open-ended question about that can help. And all of these good burnout prevention things that hopefully you get a little bit more in your education as you go along, of like trying to pick where you work and having good coworkers. This one kind of goes with we had Gandhi quote earlier, right? But any of you who've camped in mosquito country, remember that about advocacy? And then this one as a resource that is by a local social worker that is used in lots of trainings. If you ever see her name, Laura Vandernoot-Lipsky, she does a lot of trainings for healthcare for the homeless providers and other providers, actually now nationally. But she has a really excellent book that is on how to do burnout prevention for yourself. So that's like a compacted version, obviously, of what a longer training that I usually do. Any questions, comments? No? All right, thanks.